I'm going to move on now because we will run out of time. We're slightly late for now for Professor Thomas Fischer, and I'd most welcome to introduce Professor Fischer from the Charité University Hospital in Berlin, Germany. He's done very much a lot of work both in ultrasound and radiology, and he has produced some very superb research work on contrast enhanced ultrasound, but he's going to talk today about more advanced applications and new technical developments. Professor Fischer, over to you.
Yeah, so dear Paul and Dirk, first of all, I have to say thank you so much for this kind introduction. And of course, I have to tell you, fantastic talks before. So very nice colleagues and very nice results. And today, the story is we have to talk first on highlight interventions as well as ultrasound fusion. So my idea is to give you a short introduction on this topic. I'd like to briefly outline the possible indication of the use of ultrasound fusion imaging in terms of detection and localization, of course, of focal liver lesion, but also for interventional procedures. We have to move on to multiparametric ultrasound, including contrast enhanced ultrasound, and last but not least, a very short outlook. So starting with this very short introduction, why we should implement contrast enhanced ultrasound in our daily practice. I think that's easy, and we can summarize this with this paper because we have a very low rate of anaphylactoid reactions, and it's approved also for pediatric liver imaging, and of course we can use this in adults. But what is the value on ultrasound fusion imaging? So this slide is named just one case. Please first have a look on your right. That's a view on the so-called ultrasound platform view. It's a DICOM dataset from a CT scan. And we see clearly here a mass in the right kidney. We see a lymph node metastasis, and we see also a lesion in the liver. And the idea was this is a metastatic disease of a renal cell carcinoma. This is how it looks like in the ultrasound scan. The next step is for the fusion. We use an automatic segmentation of the kidney and the liver mass. And then we have to move on to landmark-based fusion. And you can see clearly the ligament, the gallbladder, the lymph node metastasis, as well as the renal cell carcinoma here. And the next step is to use contrast. And interestingly, in this early arterial phase, we see a very strong enhancement, and the lesion is much bigger in size than estimated before. And on your left, if we switch from the kidney with the central necrosis via the liver, we see no washout in this huge mess. And once again, the lesion is much bigger than estimated before. So our final diagnosis was an HCC, and of course, totally different story for this patient. Next step is to get material from the kidney. And you see, we use contrast application to see the central necrosis of the renal cell carcinoma. The patient is located in a prone position, as you can see here. And on your right, we use often the so-called blend mode to visualize perfectly here the overlay between CT and ultrasound, and once again, to have a nice planning feature for the central necrosis. Next step is to have a procedure planning. You see the necrosis, that's our landing zone. And so then we can have a nice application of this procedure. Starting first with the insertion point on the skin. Next, we go in real time. You see the TrueCar here. And then step 2, the dotted yellow line represents the needle tip. It's very easy to handle this and to confirm your perfect insertion in correlation to the renal cell carcinoma. And then the final result, we are perfectly in the landing zone after this planning procedure. This is very useful also for repeated biopsy, for molecular analysis in tumor patients. And that's once again an example of liver metastasis in a patient with prostate carcinoma. We see the dotted yellow line, and this is once again the TrueCar. And on your right, you can do your biopsy analysis as often as necessary. So therefore, I can tell you from this one case, we can say we have a better confidence, a very nice visualization with this tool, a precise planning, and of course, a better safety and efficacy for our patients. Another interesting case, follow-up of a tumor patients, a young lady with a rare case of an adrenal cortical carcinoma with a single liver metastasis after surgery. And this is the corresponding finding on T2-weighted MR scanning, where you can see a hyperintense rim after radiation exposure, which perfectly with the contrast enhanced ultrasound. And we see also clearly the hematoma after surgery. There is no reperfusion, so well treated focal mass here in that example. And hopefully for the future, we get all this information in 3D so that we have an automatic segmentation, we get automatic contrast material, and then we can correspond the findings in MR and ultrasound for better and reliable follow-up in this patient procedure. Next interesting case. This is once again follow-up of a patient after lymphoma treatment, and there was a splenic lesion after the treatment, and this was an MR scanning in 2015, and that's the live scanning procedure in 2020, and we see immediately there's no progression of the size of the lesion. We can see beautiful the enhancement pattern here of the lesion of this rare case of an littoral cell angioma, including multi-parametric ultrasound. And first of all, for this webinar, we start with yin and yang, because if you see such a lesion, sometimes it's unclear to have a clear result. Is this a malignant or a benign tumor? But if you see contrast enhanced ultrasound, immediately you should tell you this is definitely a hemangioma. Good news for the patient, and often we use the so-called P-code technology, a stabilization tool where you can see perfectly the peripheral globular enhancement. You see the heart is beating, no trouble, and we are pretty sure this must be a hemangioma. Next, multiparametric ultrasound. For this focal lesion, you see a lobulated one, you see a central artery, higher stiffness of the lesion. We see perfectly after 11 seconds the inflow via the central artery, a complete hyper-enhancing story after 20 seconds, and also the central scar is visible after 2 minutes. And of course, this must be an FNH. So everything together. Now, image fusion. Interesting lesion, a huge one, very soft, and we get this result from the MR point of view. We see an early enhancing tumor, some artifacts based on bleeding. And next step is to look in the portal venous and late phase, and we can see a slight washout in the late phase. And this was confirmed by an adenoma after histological analysis. How good we are. And if you do this inconclusive findings on cross-sectional imaging, we can say, yes, we have a very high sensitivity and specificity, especially if we use this for very small lesions. But sometimes this is not helpful, especially if you have patients with having fatty focal liver disease, where you can see there is a problem to visualize the dorsal segments of the liver. And in that example, there's a simple switch to another transducer technology, which is named DAX transducer, where you have a better penetration, and now this liver metastasis is very well visible also in the dorsal segments of the liver. And you can correspond to the same finding here in that patient, where you can see trouble MR scanning, ultrasound, and live scan. And once again, we get in trouble with the visualization on this dorsal portion of the liver. And once again, switching back to the DAX transducer, now you can see simple beam mode scanning. You will picking up all these tiny liver metastases very clearly with this new transducer technology. Next question, Bosnia classification. And you can see here, this is a nice publication where you see their Bosnia classification based on CT as the golden standard, correspond very well with a Spearman raw correlation of 0.937 with the Bosnia contrast enhanced ultrasound analysis. And hopefully also for this new update, we get in touch with this Bosnia classification for contrast enhanced ultrasound. And that's an example where you can see this focal nodule, which should be classified as Bosnia for a cystic lesion. Another interesting case where you can see, this is once again this MPR view on the ultrasound platform, automatic segmentation of a focal mass of the kidney. Contrast material was not given in the MR scanning based on contraindications. And then we use this fusion mode to use the vascular analysis based on contrast enhanced ultrasound. We see a rim-like pattern, early enhancing tumor, and this is a central necrosis, and this should be not longer classified as Bosnia for cystic lesion, because this is a clear renal cell carcinoma. Next step, I fully agree with Dirk. This is our overview on the EVA treatment story. You see, we use once again this automatic segmentation. There is no endoleak visible, and this is adapted to our guidelines. We do this after 6 months after surgery, and this is the new S3 guideline for Germany. Also, once again, neovascularization, that's a good case in point. And if you look to the linear transducer with this contrast application, this is a very nice result to have no contrast inflow in this plaque here, and we see the perfusion of the muscle very well. Another interesting case to see the multi-parametric ultrasound setup. There's a nodule in the thyroid as well as a nodule in the jugular vein. And you can see this nodule is stiff and we see some vascular architecture inside. That's the collicular duplex ultrasound to visualize this nodule. And next step is to use contrast, inflow in a common carotid artery, inflow in the nodule in the thyroid, and inflow in this nodule in the jugular vein. And in the late phase, we see a so-called rim. And if you look very carefully to the operation theater, you can visualize beautiful this pattern here once again. There's a nice publication on it. And so our idea was first, this should be a thyroid cancer, but unfortunately, this was a metastasis of a renal cell carcinoma 10 years ago, and we don't get this information before from the patient. Return to play. So you can see that's me, and that's after a knee injury 6 months ago, and now I'm coming back, and it's absolutely the actual story where we have the question follow up with fusion imaging for these sportsmen or athletes. You can see this is the adductor longus muscle with an injury here 4 days before the fusion starts, and then we start, of course, with conventional beam mode scanning. It's not easy to handle this minor injury based on ultrasound, but if you get in touch with ultrasound fusion, you see clearly this hyper enhancing area here. And if you use contrast material, we can see clearly there's no structural defect on it. And so we can visualize this is a grade 1 injury, which is now well visible also on ultrasound. And of course, this is an important information for the soccer player to get in touch on the field. Return to play is necessary. Next, 2 sportsmen on the left, you can see here the severe trauma after a grade 2 lesion 14 days before. Nice corresponding findings on ultrasound with an edema, structural defect also on elastography and contrast enhanced ultrasound. So no return to play. And on your right, you see there's a small structural defect 14 days after the trauma. And we get also nice results from the contrast inflow to see there is mostly a regular architecture of the vascular flow. And so we can follow up immediately these sportsmen very carefully after MR scanning. A short outlook on that. All of us will talk on AI and ultrasound where we are. I have to say we are exactly at the point of an autopilot, so we have to reduce our workload, and we use this method for have a better reliability and safety for our patients. That's the status today, but for the future, you can see on your right, there are some interesting publications from China using this method for lymph node staging. And this is once again a soccer player. There was an injury on the elbow, but it looks very strange. This is definitely no hematoma. It's very stiff, and we see vascular architecture inside. And the next step is to use this contrast application, regular lymph node, a suspicious one, and then we picking up this material using this puncture procedure with a 14 gauge needle, and the final result was a mantle cell lymphoma for this sportsman, a very rare case here on this localization on the skinny surface on the elbow. And this is how it looks like in the original image. We use all the concept now, elastography, soft appearance, and contrast inflow in this reactive enlarged lymph node, no washout, in contrast to this stiffer metastasis here with an early inflow and very fast washout, and everything together with the shape and with all other features should be integrated and adapted to our AI stuff for the future. So in conclusion, ladies and gentlemen, I can tell you contrast enhanced ultrasound and shear wave elastography, which is named multi-parametric ultrasound, should be integrated into our fusion concept. It makes the diagnosis more severe, and quantitative measurements is the future of ultrasound. You have seen some nice cases on NSK, lymph node, small port imaging, the DAX transducer, especially for new penetration depths and liver imaging. This is also very, very helpful in fatty liver tissue. and ultrasound should be adapted to the bioacoustic variations of every patient with different tissue densities, stiffness, and absorption levels. And last but not least, I have to answer the question, and I have to tell we implement contrast-enhanced ultrasound in our daily routine, and I have to say thank you so much for your very kind attention. Thank you.
Thank you very much, Professor Fischer. Excellent talk. I really also learned a bit about what new technology is available. I must say the fusion imaging has improved immensely over the years, and quite now, as you will probably confirm, it's really very straightforward to use. And also, if you're going to do an image-guided biopsy, is it always best under ultrasound for the patient? What is your opinion?
Yeah, in my opinion, yes, because it's very fast, it's safe, and of course we have to save also the scanner time on a CT scanner. So this is our, let me say, workhorse, and so it's much easier to use this in the ultrasound department to have this puncture procedure also in very severe cases where we use often this fusion procedure. So we
Yes,
have a
and
clear switch between CT and ultrasound.
yes, and also if you're the patient, it's much better and more comfortable and reassuring if the practitioner is with you the whole time, instead of you being everyone shuffling out of the room and repeating the CT. And this is particularly true, of course, in the younger patients and the children in particular, if you're doing procedures on them. I have one question from the questions. Do you know if there's software for volumetry, for example, in liver or liver lesions?
Yeah, at the moment this is a trouble because we don't have this nice software to get also volumetric results. It doesn't exist in our daily routine, but we work very hard with different companies on this topic, and hopefully next year we can present these results, because I think that's very, very important to get a tumor load on a patient, to select the whole volume on metastasis on the liver, to be sure and more comparable with the CT scanning.
Yeah, absolutely. There, one other question. I mean, I'm sure you'll be an advocate for this, but you talked about Bosniak CIS classification. What are your feelings on the where ultrasound and contrast ultrasound in particular lies with this classification? Are we better, or will we be better, or should it always be CT?
Yeah, from our point of view, we are very good comparable with the golden standard. And the golden standard at the moment is CT. So that means ultrasound and CT, it's nearly the same. And it's very brilliant for ultrasound. Of course, in some cases, MR is superior. So we changed our setup. We used mostly ultrasound to control these patients. And if there is an unclear finding, we underwent to an MR scanner. That's our setup. So we skipped the CT evaluation. Of course, if you have a routine staging CT, whatever, we used ultrasound to correspond these findings after Bosniak.
Yeah, and of course, with anything, if the gold standard tells you you're wrong, even though you know you're better, you can never get better than the gold standard. So
yeah,
we'll
of
never
course, that's
prove
a
it.
problem. You can discuss that we can see better the slide septic areas. That's fully clear.
Yeah.
But I think there's a value on each modality. And so ultrasound is an easy problem solver. If you get all these renal cystic lesions, there are so many lesions day by day. So I think ultrasound is the key message. Of course, also with better cost effectiveness.
Yes, and we've seen this cost effective in the liver. I'm afraid we've run out of time. There are many other questions coming through at the moment, and I'm afraid we can't answer all of them. But I would like to thank all our speakers today. I think it's been a very interesting session. Enjoyed some of the images, which were exquisite. And I hope this actually influences you to actually use this in your clinical practice, use contrast enhanced ultrasound as a problem-solving tool. It's not going to replace other imaging modalities, particularly CT for staging, etc. But it certainly gets to the point in question and answers it. And so we should hopefully see more of you implementing contrast enhanced ultrasound in our clinical practice, particularly across all countries in Europe, where there are different methods of practicing, whether it's doctors, physicians, sonographers doing the ultrasound. It's to actually get people to start using it more. thank you very much for listening. And I believe there will be a recording of this available on the EFSUMB webinar. Thank you very much, everyone.
Bye.
Thank you.
Thank you.